Today, along with Lorenzo and Jadila, we are presenting the problem we focused on, which is sepsis caused by pneumonia, and the solution we built. First of all, the reason why we chose this particular topic is that sepsis caused by pneumonia is one of the deadliest conditions in the emergency department, especially in patients over 55. In these situations, every hour counts, and unfortunately, the current standard of care forces doctors to start empirical antibiotics, which is basically an educated guess, while waiting for the microbiological cultures that can take up to 3 days to have. This delay can lead to incorrect treatment, higher mortality, and it contributes significantly to antibiotic resistance. Our goal was to remove this guessing phase. So for this reason, we set out to design an algorithm that helps doctors choose the right antibiotic from the very beginning, while still respecting antimicrobial stewardship principles. Instead of relying on cultures alone, our system analyzes all the critical information available at the bedside, such as vital signs, lactate, labs, the SOFA score, biomarkers like procalcitonin and CRP, EKG data to avoid QT prolonging drugs, imaging like X-rays and CT scans, patient comorbidities, risk factors for multi-drug resistant organism, and even the hospital's local antibiogram. Furthermore, the tool also checks allergies, flags potential drugs interactions, and adapts to local resistant patterns and local stewardship rules, which is essential for a safe and appropriate therapy. By combining all of these informations, the algorithm can provide clinicians with a personalized, guideline-based antibiotic recommendation within minutes. And the aim is simple but impactful. Start the correct therapy faster, reduce mortality, and slow down antibiotic resistance. This is the foundation of the product we built, a decision support website designed to bring precision and speed to one of the most time-critical decisions in medicine.
Okay, so these are the actual steps that we've taken. First, we used ChatGPT to create a vigorous PRD based on the clinical guidelines we've researched. Once we had the requirements, we used Lovable to instantly generate the front end. And then we connected Lovable to GitHub and made the repository on GitHub public. So this could allow us to clone the entire project directly onto Cursor, so we can start to edit there. Then here we ran npm install. Then we launched the program to see our first live demo. Then, in order to power the medical reasoning, we generated OpenAI API keys and added them into the project so the AI features could work. Finally, we needed secure backend for the patient's data. We integrated Supabase. In the very end, we wanted to make our data safe and secure, so we asked the ChatGPT and AI agent in Cursor for security advice. So following these instructions, we moved our secrets into the environment variables, ensuring that no sensitive keys are ever exposed in the code. Okay, so these are the steps that we've taken.
This is our website, our pneumonia sepsis antimicrobial decision support. We can add all the patient information, the age, for example, the vital sign, so the heart rate, for example, the blood pressure, or the respiratory rate, for example. We can add the temperature, we can add the lactate, we can add the laboratory values, for example, the CRP, the procalcitonin. We can add the comorbidities, the risk factor about resistance, or we can add the safety profile, the drug allergy of the patient, for example, penicillin. So our algorithm, after integrate all these parameters, can generate a recommendation about the correct antibiotic therapy. So give us information about the SOFA score, so the sepsis score, the predict pathogens and the antibiotic recommendation, in this case ceftriaxone and azithromycin, the dose and the alternative and the escalation plan. So this is our algorithm. We can certainly improve this algorithm. For example, we can connect the hospital software to these to transmit directly the parameters to make all the process faster. So we have another problems. We have to demonstrate that our algorithm is superior than the empirical decision making. So we want to create a multi-centric study to find the parameters that are most associated to the prognosis and the overall survival. After that, we want to create a learning machine that help us to predict the best antibiotic therapy in patients with pneumonia-induced sepsis to reduce the mortality, improve the overall survival, reduce the antibiotic resistance, and respect the antimicrobial stewardship.